Thank you very much. I'm very grateful of being here today. Thanks for the invitation, and please give me a sign if I'm running long. I'm afraid I will present another niche topic, actually, but I hope that it will be interesting somehow, and I will indeed focus on children, and I will try to disentangle a little bit what is done currently in the clinical practice with a focus on neurorehabilitation and what I believe is missing, which is in the domain of my personal opinions, of course, or at least a personal perspective. Okay, I would like to start by linking to what was mentioned earlier before during this interesting day. Disorders of consciousness encompass a range of diseases that go at the lower boundary from coma up to the minimally conscious state, with or without communication, and up to the severe disability that for us is the upper boundary of the disorder of consciousness. And in children, we have this first problem that actually we are using definitions that were actually defined mainly by observing adults. And so the first observation is that in children who are around 6 years of age or older, we see, and we have literature that attests that, we see that these definitions more or less hold. But we have a general lack of evidence for children younger than 6 years of age, and particularly we have, I would say, a complete lack of evidence for children younger than 2 years of age. And part of the problem is the assessment, and particularly the fact that assessment relies on features that we observe, or presence or absence of signs, such as, for example, visual tracking, common following, verbal communication. But as a developmental milestone, these evidences are usually not present at birth and develop at different times in the controls in the healthy children. But the problem is even deeper and goes to the very definition of certain states of the disorder of consciousness. And here I will just make one example to make my point. Let's think at a minimally conscious state. This is defined as a minimal, reproducible, but inconsistent awareness with language comprehension and expression. Now, what we observe in children, in toddlers and children of 1, 2 years of age is actually a minimally reproducible and minimally inconsistent language understanding and expression and communication with adults. And so, in a way, the very definition of the state clashes with the developmental milestones of controls of healthy children, in a way. And from here, the difficulty of assessing the states. So what has been done for long has been just to try to insist on maximizing the arousal in the patient so that we maximize our chances to observe those characteristics, those features that are assessed by the scales in adults. And so from here, a wide literature, and here I have collected a little bit of techniques that we read sparse inside the literature, strategies about child's positioning, optimizing the time of the day when the patient is assessed, the repetition of the assessments, the selection of the type of stimuli, the salience of the stimuli, making the session short, and so on and so forth. We could go through a long list. This is of some use, of course, but clearly this is not enough. So the next point is really to have some tools which are specific to children and which were designed specifically to them. So I won't go into the details because of the time, of course, but I leave a number of references. But the idea is that here, surprisingly, the tool which was recently, has been recently most used in the pediatric literature is a tool which was actually developed for adults, by observing adults, and particularly the Coma Recovery Scale Revised. This is a gold standard in adults, and its characteristic, if we can mention one, is the fact that it assesses the motor domain with a great emphasis. That's already seen in adults. And the limitation, if you like, is the fact that it severely penalizes the scoring of patients who have a cognitive profile not necessarily profoundly impaired, but for sure poor possibility of manifesting their signs due to a severe motor impairment. This is seen, of course, also in children, and a group in US, led by Beth Slomine, who did a wonderful work on children, proposed a modification, basically, of this scale, which is the Coma Recovery Scale pediatric version, which incorporates a domain, which is the domain of affection, and incorporates items such as, for example, the cuddles and affectivity type of stimuli. And this seems to work a little bit better, at least for patients older than 3 or 4 years of age. In Europe, we see that the two mostly used tools are the Coma Near Coma scale, thanks to the very basic type of stimuli that it delivers, and items, I shouldn't say probably stimuli at this point, and the level of cognitive function assessment scale, or Rancho-Lozamico scales. There's a general agreement that these two tools should be normally be delivered in combination, or alternatively the CRSR or CRSP and the CNCS. And then we have other tools which were developed mainly in the US space, and particularly I want to mention PADOC because this was designed and then later tested in children, although of an older age, let's say towards adulthood. I'm trying to proceed to the next slide. Okay, sorry. One point I would like to make is that the scales, particularly, for example, if we look at a Coma Near Coma scale and the CRSR, assess the spectrum of the disorders of consciousness, but their sensitivity is different depending on the specific states. And so, for example, we see how in the top image, for example, the Coma Near Coma scales is able to do a more fine-grained assessment of the deeper levels of consciousness, such as the light coma and the vegetative state, while, for example, the CRSR is more able to really disentangle the different shades of recovery from the minimally conscious state upward. And so very often we see a kind of quasi-quadratic relationship in between the scales, and that's the reason why the recommendation is to use at least two, of course, with an additional burden to the assessors in terms of time and resources. One other point I would like to make is the fact that, of course, different tools can also score patients in different levels of consciousness. And so if you look at the image at the bottom, we see, for example, that with one scale, a patient who is in a light coma might end up being in a vegetative state with another scale. That's also the reason why we recommend to use at least two, because this gives us the possibility to really minimize the false negatives. And we don't have to fall into the trap of thinking that one scale is more optimistic or pessimistic with respect to the other, because as we see, for example, in this case of the Coma Near Coma scale, we have a little bit more of patients who were, in this example, in this cohort, rated in a light coma, but we also see the capability of the scale to really identify minimally conscious patients in minimally conscious state plus with respect to minus. So the reality is a little bit more complicated than just a simple decision towards a positive or a negative bias. If we increase the picture, I would say these scales are normally used in the post-acute phase, while, of course, we have a phase of assessment at the moment of the trauma that is usually done with the Glasgow Coma Scale, as we've heard before. For children, we suggest you always include also the 4 and, of course, the pupillometry, and then the Rancho-Rosamigos scale and the Common Neurocoma scale, and then, of course, down the line, it is important to assess the functional ability of the patient, and this is done normally with a pediatric version of the functional independence measure, which is called WIFIM, and then, of course, we don't have to disregard the inventories for the patient's well-being in the chronic setting or at home. This is the neurobehavioral assessment, if you like, but a few years ago, the concept of cover cognition was proposed as a description of those patients who can't really demonstrate a residual cognition neurobehaviorally, which nevertheless can be assessed at a central level. A few years later, and particularly in 2024, the Brian Edlow's group proposed a workflow for assessing the readiness of patients, adult patients, for being assessed in this second dimension, which is purely instrumental. In terms of pediatrics, I just want to mention the fact that we don't have a workflow ready for children yet, but we also don't have any reason to think that it should be any different in terms of macro areas. So basically, the idea is to assess preemptively that the patient doesn't show any a huge confounding effect, so that this would mask at a central level the presence of consciousness, such as, for example, status epilepticus, and then with minimal sedation, the patient is brought to the assessment, the neuroimaging assessment through functional MRI and task-based functional MRI. Now, here, from my point of view, the only warning is really that the task has to be accessible to a control of equivalent age, meaning that we don't have to fall into the trap of sending the patient to the neuroradiology department, hoping that the task-based type of paradigm that is normally proposed to adults can be replicated as such in children. The other topic, of course, is the light sedation in children in an MRI. We know, all of us know, that in disorders of consciousness, the patients are not necessarily still, and that can create some issues. In terms of outcome, of course, we know from the literature from adult TBI and brain injury in general that we have some sort of window of opportunity for rehabilitation where certain recovery phenomena and clearance phenomena go on in the brain, and then we have certain degenerative mechanisms such as the tau deposition and so on that at a certain point take over. So we would be inclined to think intuitively, I believe, or at least this is what I've believed for some time, that if the injury is earlier, then maybe the patient has more neuroplasticity and can recover better. What we see is actually the opposite, meaning the earlier the injury and the worse is the outcome, and this probably corresponds a little bit more to a model of accumulation of damage with the time rather than an advantage in having the damage early. In terms of etiology, we see the patients with a deep anoxic and hypoxic damage do unfortunately worse than patients with sort of consciousness due to TBI, given the same conditions at the beginning, at the admittance to the ICU. This is consistent with the literature in adults. And in terms of how they respond to rehabilitation, what we have observed a few years ago is that we have some groups of early responders, meaning children who start either already functionally very well or at a lower level, but they really engage with rehabilitation and can have a fast recovery over the time. But crucially, and I would say there's an ethical implication which is not negligible here, we observe that by automatically stratifying with machine learning these patients, there's a group which falls into what we call the slow responders, meaning children that recover steadily but slowly, and they catch up with the early responders within basically a decade, 7-8 years. And this clearly has profound implications because we can bring back the students, the children to be students, to the schools, and then to be functional adults. But of course, this has implications for a continuation or discontinuation of therapy and intensive rehabilitation, especially in systems which are based on insurance. We also observe another cluster of patients who are the non-responders. And if we go back to see the original characteristics of the patients, we see that these patients are, for the most part, epileptic. So patients in which, in whom the epilepsy profile was not resolved. The epileptic seizures were not resolved. And this brings me to the next slide in saying that in terms of treatment, the first action is really the epilepsy containment. Nowadays, we have several anti-epileptic drugs available. There's still a little bit of trial for error, but for sure, many patients can have their seizures controlled, and there's prevention of further damage. But some of them candidate for resective surgical intervention, and then we have other tools which are available to kind of indirect tackle the problem of epilepsy, such as the ones that I mentioned here. The second aspect is the pharmacological treatment for the disorders of consciousness, and in literature we find evidence of prescription of dopamine agonists and pharmacological compounds with certain GABAergic effects, such as zolpidem. Now, here we fall a little bit into a safety paradox in the sense that we see that the younger children are less prescribe these drugs, and so we have less evidence to guide the prescription to the young children, if you like. But one other concept, very well expressed by McLaughlin in her paper, is that we also have a problem of variability. The variability of the dosage at the moment is way higher than the variability which can be explained by weight and by age. And so there's a need of standardization in a way. The other aspect is that these drugs have side effects, and so we see, especially zolpidem, prescribed, for example, in occasions for Christmas, for Easter in a families, rather than for a continuous type of treatment. And of course, these patients come with organ dysfunction that can affect drug metabolism, and this, of course, vouches for certain caution in the prescription. And the last point I want to make is that these drugs don't work for everyone, and there's a lot of trial for error in this. So we know that amantadine will only work for some patients, zolpidem will only work for some patients. Why? Well, the assumption, or let's say the hypothesis, is that there is a problem of neurotransmission profile and neurotransmission damage, but unfortunately this is not normally characterized in clinics, and so you just have to try. The other aspect of the treatment is the rehabilitation, and particularly in this field we use neuropsychostimulations, and for our tiny ones, olfactory, gustatory stimuli together with motor and tactile stimuli is what is most used. Auditory and visual, yes, in theory, but some patients come as deaf or blind, and for the visual stimulation you also need some collaboration by the patient, meaning keeping the eyes open, and this is usually not achievable, at least with the severe ones. And there's for sure a push in the practice currently towards the multisensorial stimulation with an affective dimension, as in fact is demonstrated also by the work of Beth Sloman's group. One other approach is the use of potentiation of the residual cognitive activity, and here we have the domain of brain-computer interfaces, and here some of you might claim that, yeah, these methods have been around for a while, but there's never been a huge breakthrough. So our opinion with Nico Schiff that we put forward is that there hasn't been sufficient accent on assessing the readiness of the patient and choosing really the right technology in consequence of the residual abilities of the patients. Often the science has gone about it in terms of having an engineer go into a lab and proposing a machine and asking for patients for the machine to be trialed out, rather than the opposite, the other way around. The other aspect is that patients are quickly changing, and also their responsivity and their capability to respond is changing. And for this reason, brain-computer interfaces have to go through a systematic review, in a way, of the mode of functioning with a specific patient. So all in all, I would say the last trend I can see in practitioners in this field is a paradigm of care where the medication, the pharmacological medication is delivered in a synchronized manner or in a timed manner to really leverage on the pharmacokinetic so as to potentiate the other interventions, such as the manual rehabilitation, such as the cognitive rehabilitation, such as the brain-computer interfacing and the potentiation. And in a way, this is nothing new, but in this field is something pretty new. Now, I would like to kind of conclude in the last part of my presentation by mentioning some current concepts that have been around in the community, in the scientific community of consciousness science. The first of which is a strong push for looking at DOC as a continuum of care from the injury and up to the home care. That was very much encouraged by the Curing Coma campaign and the NINS, the NIH that was mentioned earlier today. For children, the situation is even more complex because they can come from an NICU, from a PICU, and even normal ICUs, let's say, for adults. And so there's a siloed literature of the ICU care with ICU literature enrolling patients at the admittance to the ICU. And then we have all the rest of the literature dealing with the rehabilitation, which normally admits patients in a way and enrolls patients in trials at the admittance to the post-acute care or rehabilitation care. And so we lose this continuum indeed. The second point is to really stratify in clinical trials to gain precision in evidence. Disorders of consciousness in children are disorders of consciousness, full stop. There's no disorder of consciousness due to TBI, disorder of consciousness due to anoxia, and so on in the literature. And so drilling down to the etiology is probably what is needed. And then a strong push for the use of imaging and EEG, especially by the EAN. So what's missing in conclusion? Unfortunately, not rocket science. We have many underreported clinical features of pediatric DOC, just to start. We don't know, we don't have, for example, an average number of days from injury to common following for the different states of, for the different disorders of consciousness in children. We don't have information about bladder management, bowel management. So, as I said, it's not rocket science, but this characterization would be critical to improve the recruitment in clinical trials. And secondly, this idea of continuous of care vouches for a sustainable model. What does sustainable mean? Well, for sure, an integrated care for the patient, a standardized care, which is provided regardless of what is available at the territorial level, at the council level. So immediately, there's an objection about the costs, but I believe that the sustainability has to also be assessed in terms of the cost to the family and the cost to the society. These are children that if they don't go back as functional adults, they will remain on social care for the rest of their lives. We very often see dropout from the workforce of one of the carers, usually, but not always the mother, and mental issues that have to be addressed down the line for the family. Of course, these patients go back to the hospital very frequently, and so empowering the family also avoids readmittances, and all of this goes into a definition of sustainable model as a whole for society. And of course, as I said, stratified clinical trials, because through these we could really improve the precision in whatever evidence we gather. What I believe we don't need is one more neurobehavioral assessment scale, one more clinical scale. Rather, we should probably improve what we have. And with this, I think I can really thank you for your attention, and I'm happy to take questions.
Thank you. I think we have time for maybe one question. Do you have anyone online or anyone in the room? Yes, I have a question over there.
Thank you for your work. Wow, that's really loud. I have a question about, it might be a little out of left field, it might be unrelated, I'm not sure. I'm curious if you have any longitudinal data looking at adverse childhood experiences and early childhood trauma more related to brain injury that's not related to epilepsy, and if there's longitudinal data, especially around later propensity for dissociation or any other kind of, this is making it broader, but any other psychiatric issues, but especially kind of trauma-related psychiatric diagnoses.
Yes, there are, but in this field, I would say most of the evidence comes as low evidence. So we have case series, we have single cases which are reported, and unfortunately there's also a problem of a tendency to report non-standard presentations, non-standard cases. And so the difficulty of this field is to really navigate through an accumulation of low evidence rather than an accumulation of clinical trials, or even the presence of one or two big clinical trials addressing a problem. And I would say the other aspect of child pediatric disorders of consciousness, the other topic, is that very often the agreement on the very definitions is lower with respect to adults. So I would say, to answer your question, yes, you can trace back elements in the literature, but it is much more unlikely to identify them, depending on the specific problem you're addressing, a clinical trial or even a big observational study that really addresses the problem you are, let's say, you have at hand. So that's really the problem of the field. And the work we are doing with the instruments that we have through the International Brain Injury Association is exactly that of creating some sort of meta-analytical approach to the literature to collect single cases, rate based on the evidence of each study, and then collate the results. But what we observe is that we have a massive bias on non-standard presentations, which are more likely to be published, probably, but also accepted by the journals rather than the standard presentations.
Thank you. That's all the time we have for questions. Another round of applause. We can start the next